Which one? Yeah, proximal tubule, the carbonic anhydrase inhibitors. So, what are the clinical uses of those? Glaucoma. What else? Yeah, very good. Yeah, altitude sickness, that's how you use it. And in clinical practice, when you have a patient with a lot of volume overload and the bicarbonate is very high, you can actually kill two birds with the same stone. You just give a little bit of acetazolamide, and then you will get rid of the volume and you get rid of the high bicarb by doing that. Okay, and what other diuretics? They don't have an antihypertensive effects. So they're called the aquaretics. Have you guys heard about the aquaretics? The Vaptams for management of hyponatremia. Have you ever heard about tolvaptan and conivaptan? And, yeah, so those medications they excrete free water, but it's not no problem. But they're not antihypertensive. And just now that we're talking about diuretics, I just wanted to cover it. So then those are the diuretics. Then we have ACE inhibitors and ARBs, very effective across the board. They are equally effective in clinical studies. They've done non-inferiority trials, and we know that one is as effective as the other, so you can use one or the other depending on your preference. Very effective medications. I teach students and residents that you have to have a very compelling reason not to give this to a heart or to a kidney patient, because in my field there are very few things that I can do to help a kidney disease patient, and negating that medication is a disservice to your patients. So some doctors they immediately take it off because the patient became hyperkalemic. Guess what? Did you educate the patient about low potassium? Did you play with other things? Maybe the patient is a little acidotic. You just need to give him a little bit of bicarbonate. Did you actually review, is the patient constipated? Remember, the gut helps the kidney get rid of potassium. It's very inefficient. It's like 5 or 10% of the handling of the potassium happens in the gut. But a kidney disease patient should not be constipated because there is higher risk of hyperkalemia. But the only reason why a patient shouldn't be on an ACE inhibitor is angioedema. That's how I see it. Because the other stuff I can handle. If your patient is compliant, and if you walk them, you grab their hands and you walk them through, you tell them, you know what, I want you to really give up those bananas and those avocados, because this medicine can really help you get to where you need to go. And another example that I use that is very useful, and I want you guys to start telling that to your patients, is that some doctors, they prescribe it, they go back for a lab test in 1 week, and the creatinine bumps, and they immediately stop it, and they say like, oh no, this guy has developed worsening kidney function. I want you guys not to do that, unless there's a ridiculous increase, like more than 30% increase on the creatinine. Why is that important? Because it is expected that you have a transient decline on your GFR when you guys give ACE inhibitor and ARB, because of the way they work. They're gonna block renin, or they're gonna block angiotensin II production, and they're gonna cause vasodilatation. Vasoconstriction of the afferent arterioles, and it is expected that the GFR is gonna drop a little bit. So I want you guys to always tell that to the patient. This is the example that I use. Especially now that the patients have access to information. I don't know if you guys know, but where I work, you get access to everything. And now, starting this month, you're going to get access to whatever your doctor writes on the note, on the chart, you're going to get access to. So there's nothing hiding. Everything is very transparent. So because of that transparency, patients have a lot of questions. Hey, my creatinine, how come my creatinine was 1.5 before I started this medicine and now it's 1.8? So your answer to that question is going to be like, I want you to think like that engine was running 5,000 revolutions per minute. By giving you this medication, I'm trying to bring that engine to 2,000, because I know if the engine works slower, it's going to last longer. And I use that so the patients can actually imagine what I'm talking about, because they're not going to know anything about this artery and this physiopathology, and they're not going to understand. You're going to overwhelm them with this $5 worth of like vasodilatation, relaxation, whatever. So, but if you tell them that, they're likely to understand it and to stay with it. And that's, again, I cannot emphasize enough communication. You need to tell them these things, but you have to have a very compelling reason. And the other thing that's important in clinical practice is that if you have angioedema with an ACE inhibitor, that does not preclude you from using an ARB. There is a small chance that you may have angioedema with an ARB, and some doctors become very uncomfortable prescribing it, but you're not going to be faulted if you prescribe losartan after somebody had angioedema on lisinopril. And what I do is I just give them an EpiPen, and I just tell them, you know what, just take it easy that day and take it, and let's see what happens. But there shouldn't be really a reason to fear using an ARB after you failed an ACE inhibitor. Another thing that's very important, and I want you guys to memorize this: if you see a patient that is getting an ACE and an ARB, that patient is being mismanaged. That means that doctor hasn't probably touched a book since 2010, because there is a very famous cardiology trial called the On-Target trial. You guys can write it down and Google it. The On-Target trial demonstrated that the combination of ACE and ARB resulted in additive hypotension, increased risk of syncope, and increased risk of progression to end-stage renal disease. And some doctors say, like, yeah, but patients with that combination, they excrete less protein. Who cares if you excrete less protein? You're going to go on dialysis faster if you keep that combination. So if you guys see an ACE and an ARB on the same patient, that's a big no-no. Another thing that I want you guys to remember in hypertension medicine, bad combinations are ACE, ARB. Another bad combination is combining, let's say, clonidine with a beta blocker, because you can cause, you're going to see this in clinical practice, but I'm just letting you guys know that you need to watch the heart rate. If you're combining beta blockers and clonidine, both of these medicines can cause additive bradycardia, and the patients can actually end up having a complete heart block. Another thing that's common in clinical practice, Dr. Ben-Zur does it because he's an electrophysiologist. He knows what he's doing for these complex arrhythmias. Combining non-dihydropyramide calcium channel blockers like verapamil and diltiazem with a beta blocker and with clonidine. So those three things, they have a direct effect in the AV nodal, in the AV node. And if you don't pay attention to that, you can actually cause the patients to have a complete heart block. So always remember those combinations. So bad combinations. Okay, so we talked about ACE, ARBs, thiazides, diuretics. Which other medications?
Quick question. So
yes.
You had a slide where it says for hypertension control, is it ACEs and ARBs, or first you want the
I mentioned that you do that if you have heart disease or kidney disease.
So that
if you're healthy, just hypertension, you always start with either with a thiazide, but you need labs before and after, or amlodipine. And that's what's novel about the JNC8 recommendation, is that amlodipine was elevated to a first line agent. Before it wasn't there. Now we know that they're equally effective based on the evidence that we have. And the nice thing about it is that it's pretty easy. It's cheap. Now it's available over the counter. It's available at the $4 prescription plan on most pharmacies. So that's another thing, guys. When you're dealing with hypertension, if you prescribe a new kid on the block, you're doing a disservice to your patient, because we have so many agents that are very effective with proven efficacy and safety, that you don't need to go to this fancy new combination. They take two old-fashioned drugs and they combine them in a new drug. They put a fancy name and you give that to your patient. Containing costs should always be part of your clinical practice, because you probably will say, like, well, whatever, he has good insurance. But you have to understand that, number one, patients have big copays. You will never be able to understand what the copays are. So if you prescribe something expensive, more likely the patient is going to end up leaving you. Number two, Some patients that are on the Medicare prescription plan, there's so much money that they will get covered. That's called the donut hole coverage. Have you guys heard about the donut hole? So if you exceed that number, most patients by September, they already exhausted funds, and they're not going to be able to afford the medication from August until December. So you accomplish nothing by doing that. So containing costs is an important clinical, aspect that you guys need to be aware of. Okay, what else? Which other group of medicines, you guys? Which other groups of medicines?
Beta blocker.
Beta blockers. So beta blockers. Why do we use beta blockers? So we do them for several reasons, right? Migraine prophylaxis, stage anxiety. They work pretty well if you have an anxious person. Give them baby dose of metoprolol that works like $1 million. Like psychiatrists use it a lot as mood stabilizers or anxiety stabilizers. We use them for heart disorders. We use them occasionally we use them for hypertension as an added agent. I personally use them in my practice because in kidney disease patients, amlodipine is not very effective. And I need to move to nifedipine. Have you guys heard about nifedipine? So nifedipine is an extended release medicine, and it actually I can go up as much as 90 milligrams twice a day. And textbook definition is amlodipine 10 is the equivalent of nifedipine 90. That's what the textbook says. In clinical practice, I think that nifedipine 90 it's much more powerful than amlodipine 10. And when I'm converting a patient from amlodipine to nifedipine, I always start with 90 milligrams of nifedipine. And almost always, the 90 milligram does the trick. But the nice thing about nifedipine is that I can gradually increase it by 30 milligram increments to a maximum dose of 90 milligrams twice a day. So most of my kidney disease patients, they require to be on nifedipine. But there's a caveat. Nifedipine can cause a reflex tachycardia. So I always, before I make that conversion, I give them a beta blocker. Because the times that I haven't done that, the patients, they come back to me and they tell me, you know what, doctor? I don't ever want to try that medicine again. And I ask them, why? Because it made me feel so uncomfortable. I felt like something very abnormal, like and this is the reflex tachycardia. So that's the reason why I beta block them a little bit before I give them nifedipine. But you don't always have to do it. And you're not going to find this in a textbook. I'm sharing with you guys my experience in clinical practice. I give them a little beta blocker, and that seems to work very well. Beta blockers, along with long-acting calcium channel blockers, work very well in kidney disease.
How long do you give them the beta blocker for?
I can start them at the same time. You can start them at the same time, like the day that you're doing the conversion.
And then when do you take them off the beta blocker?
They remain for as long as they're taking the...
Oh, so together.
Together, yeah. So that's another pearl that I can share with you guys for severe hypertension. Nifedipine is very effective, especially in kidney disease. Which other group of medicines? Calcium channel blocker. So we talk about, we have mostly amlodipine, but we also have the hydropyramides. We have like verapamil, diltiazem. Things that you should know is that verapamil, diltiazem can also have AV nodal blocking. They're chronotropic. They have a chronotropic response, so make sure you follow heart rate. Another important consideration in clinical practice is that verapamil and diltiazem, they're synthesized at the cytochrome P450 system in the liver, so they compete for that side of metabolism. So if you prescribe a statin, you can cause rhabdo. If you have high dose DILT and high dose, let's say simvastatin, almost always that I get consulted for rhabdo, they call it because there's renal failure, it's because the patient wasn't simvastatin 80. My advice to you guys is a bad drug. Don't prescribe simvastatin 80. If simvastatin 40 is not doing it, just go to Lipitor or some other drug, because simvastatin 80 is dangerous. I've seen 3 cases of rhabdo in simvastatin 80. So that interaction, you guys need to have it in mind in clinical practice. Is relevant to think about that. That's another reason why I'm not a very big fan. Another thing that I want you guys to memorize from now on, if you get a transplant patient and the patient is taking either DILT or verapamil, 95% of the transplant patients are on DILT and probably 5% of them are on verapamil. Do not touch that medicine because it's not intended for blood pressure control. I cannot tell you how many times I've seen this mistake by primary care doctors. They're like, oh, this diltiazem is a very weak blood pressure medicine, let me give you this. The reason why transplant doctors prescribe diltiazem is not for blood pressure. They prescribe it because by doing that, they save money because they compete for the same site of metabolism with tacrolimus or cyclosporin. Therefore, you achieve therapeutic levels with lower doses. So the minute that you stop the diltiazem, your patient is going to get under therapeutic levels of the calcineurin inhibitors and the organ may reject. I've seen this in clinical practice numerous times. So I want you guys to remember, DILT and verapamil in a transplant patient, do not touch it. It's a transplant medicine. Do not touch it. And this is an important clinical issue. Okay, so side effects, constipation, lower extremity edema, gingival hyperplasia. Pretty benign stuff, nothing really serious, and that's one of the nice things about calcium channel blockers. But nobody wants to have gingival hyperplasia. Okay, bless you. Which other group of medicines, guys?
The emergency.
So,
Which one?
Class 1 is two. Class 1 is like sodium channel blockers.
Which one?
The so talo. Wait, those are the.
the class 1 and class 2, I think those are interrhythmic samples. I don't know which ones of emergencies like hypertension.
So,
Do you use
which-
nitrates?
nitrates, great. Yeah, nitrates are great medications. They're safe, they don't have any metabolic effects, they don't cause any electrolyte disturbances, kidney problems. Sometimes they're hard to tolerate because they can give headaches, but they're very safe medications. They're short-acting and long-acting. We have the isosorbide mononitrate that needs to be dosed TID, so that I have a problem with TID dosing. That's another pearl for hypertension management, guys. If you want to make it easy, try to stay with regimens that require like once a day or maximum twice a day. When you go to like TID or QID, like hydralazine, that's the problem that I have with hydralazine. Who in the world is going to take a medicine 4 times a day? Have you ever taken a medicine 4 times a day? It's terrible. I mean, most of the times we end up not doing that. So think about that important clinical consideration with your patients. Okay, so we were talking about nitrates, and then we have the indoor, which is the isosorbide dinitrate. That's pretty cool. And you can go as much as 90 milligrams twice a day. I think is the maximum dose. You can start with 30, 60, 90, and that's an extended release tablet. You're not supposed to break it, but it's a safe medication. I use it in hypertension management of my kidney disease patients. What else? What other medicines? The alpha-methyl-dopa, pretty much a dinosaur drug. I don't use it unless there is a pregnant lady that the OB prescribed it, and I titrate it, but I've never prescribed that medicine, to be honest with you. Centrally acting, multiple side effects. Yeah, there's so many other safer choices. Hydralazine is probably safer in pregnancy. And nifedipine should never be used in preeclampsia. That's a board question, because it can cause profound hypotension that can result in really bad outcomes for the mom and the baby. So you need to stay away from very long-acting agents like nifedipine in pregnancy. What else? And ACE inhibitors, by the way, are category X. So if you have a female in reproductive age, and you prescribe ACE inhibitors and they get pregnant, that's malpractice. So statins and ACE inhibitors are category X. Always remember that. What else?
What's the cost in nifedipine with eclampsia? What's the cost?
It causes profound hypotension. You can harm the baby and the mom. You never want to use that. They use like labetalol or hydralazine, IV hydralazine. So nifedipine, big no-no.
There's the alpha one.
Clonidine?
Yeah, clonidine.
Clonidine is pretty effective. Clonidine is actually, it has two uses in clinical practice. One is in the urgent care because it's short-acting. So you don't have labs, you don't have time. You want to fix somebody with severe hypertension and give them a little bit of clonidine. Clonidine I dislike because it can cause severe rebound hypertension if you don't take it. And it also needs to be taken multiple times a day, no less than 2 or 3. And it causes a lot of side effects like dry mouth, headaches. Like, I personally am not a big fan of it. I know doctors, they use it a lot because it works very well. It's short acting, so that's another benefit. It onset is pretty quick and it wears off very quickly. But it can give you severe rebound hypertension. But there's also an option of doing the patch. Sometimes when I really have no other option, I do the patch. You know, the patch is once a week. It comes in 0.1, 0.2, and 0.3. So you gradually do it. If you want to wean off somebody from the patch, you need to give them tablets. You need to start coming down from 0.3 to 0.2 to 0.1, and then you start giving tablets until you take it out. You never stop clonidine abruptly. That's a big no-no. So, and you guys remember which other drug you never stop abruptly?
Steroids?
Yes, but we're talking about hypertension medicine. Which antihypertensive you should never stop abruptly, besides clonidine? Guys remember? Beta blockers. So beta blockers should never be, you should always taper down. And then we have hydralazine. I told you it's a vasodilator. We have the alpha blockers in patients with a little bit of prostate concern, so you can actually kill two birds with the same stone. Terazocine, prazocine, or doxazocine, Cardura. These medications are associated with symptomatic orthostatic hypotension. Every time you prescribe it, you need to tell the patients to expect something like that, and you never start them in a high dose. In fact, it's malpractice. If you give terazocine 10, it's malpractice. So you need to start with terazocine 1, and you tell them you're gonna feel this when you stand up. It's probably gonna be there for 2 or 3 weeks. After 2 or 3 weeks, it's gonna disappear, and you can start going up on the dose. But you never prescribe high dose alpha blockers to anybody, because of the orthostatic hypotension issue. So I use them, they're safe in kidney disease. Which other medications? So we have minoxidil, I told you guys, it's a vasodilator. I'm not a fan of that medicine either. And I think that's it. What we talked about, I think. Yeah. Dr. Renzo wanted me to cover rheumatology, but it's impossible. With hypertension, there's so many things that we need to talk about hypertension that we can probably, tomorrow he wanted me to do pulm, so I can do either rheum or pulm, whatever you guys want to do tomorrow, or we can try to do one and cover a little bit of the other one. But hypertension, the way I see it in hypertension is just gonna be your bread and butter. You have to know hypertension very well to be a good, strong clinician. And we're gonna need no less than 2 hours to talk about hypertension. Okay?
Just a question.
Yeah.
So the Tarzana and Verapamil, you said not with a statin increase rhabdo, just simvastatin or any statin?
Any statin. So if you're gonna give it to them, you need to be on a low dose statin. Like, in other words, you're not gonna prescribe like high dose diltiazem and high dose Lipitor. A good pharmacist will reject that prescription. But you're not that lucky that you're gonna get a good pharmacist. When you get a lawsuit, it's always because the pharmacist ended up dispensing something they weren't supposed to. But it doesn't mean that you cannot combine them. Just be aware of that side effect.
And also a quick question for the beta blockers. The reason you should taper off is to also avoid the rebound.
Rebound hypertension.
Okay.
So those two medicines are associated with severe rebound hypertension.
Which one?
Okay.
Beta blocker and then
And clonidine.
alpha.
No, beta blocker and clonidine.
Because of bradycardia?
No, you taper them slowly because the risk of severe hypertension, rebound hypertension. When you're increasing the dose, you have to monitor the heart rate because that's every time you're gonna adjust a beta blocker or clonidine or verapamil or diltiazem, you don't want to do that if your patient's heart rate is already in the 40s or 50s. You don't want to do that.
Oh, so clonidine is rebound hypotension.
Hypertension. If you stop it abruptly.
Oh, and beta blocker or something.
Correct.
Okay.
So remember, you never stop them abruptly because you can get severe rebound hypertension. Okay. Anything else, guys?
That's good. You're good.
All right. Thank you so much.
Thank you.
Thank
I'll see you guys tomorrow.
All right.
Very good.
Thank you.
Thank you for your time.
Thank you.
Let's go.
No, there's two. I think there's another one.
All right.
No, it's fine.